This discussion is going to center around the biomechanics, looking at the elbow and forearm. So we're going to be examining the osteokinematics and arthrokinematics of both joints and talk about some of the issues related to injuries that could come about within this region. So we examine the elbow joint. The elbow joint is made up of two joints. You have the humeral ulnar joint and the humeral radial joint, both of which making up the elbow. Again, we're going to treat the radioulnar joint as a joint of the forearm, so that's not directly related. While it's in kind of the elbow complex, it's not the actual elbow. The classification of the joint, it is a hinge joint with 1 degree freedom of motion, flexion and extension. If you notice, though, the axis, and you can see this on the picture on the slide, the axis is at a slight angle. So the flexion extension is going to occur through a medial lateral axis, but if you notice, the axis is at a slight angle, which just allows, again, for more functional movement at the elbow. When you look at the joint end feels, for flexion, we'll typically have a soft end feel because of the approximation of the forearm to the bicep, and your extension end feel will be hard due to the back of the olecranon contacting the posterior surface of the humerus. As far as the range of motion is concerned, you're typically looking between 0 and 145 degrees for your range of motion at the elbow. Obviously, your flexion range of motion can be limited based upon the mass of the upper arm. So depending upon the mass of somebody's bicep, that could dictate how much flexion that they can actually get. But anywhere between 0 to 45 to 145 degrees is what you're looking at for that. At the end of flexion and extension, another thing to kind of note is there are a few degrees of medial and lateral rotation that occurs at the elbow as well. So as you flex and extend at the elbow, there's a slight amount of medial and lateral rotation that occurs at the end of flexion and extension. Another thing to note when you're looking at this is the carrying angle. So you have about a 15-degree angle. You can see the carrying angle, how it's measured on the illustration on the slide. Usually about 15 degrees is a normal carrying angle. Varies a little bit differently between men and women. Women typically have a bigger carrying angle than men, so that's not unusual to see. As far as looking at the carrying angle, you can also have what's called cubitus valgus or cubitus varus. So cubitus valgus would be an increase in the carrying angle, so going beyond 15 degrees. A cubitus varus is a less than normal carrying angle, and sometimes they'll refer, this will be referred to as a gun stock deformity, and you usually see that that's a deformity that usually comes about as a result of a fracture to the distal humerus. The carrying angle also is made up of a couple different motions. So when you look at measuring the carrying angle, it's a combination motion of glenohumeral lateral rotation, elbow extension, and forearm supination are all the movements that make up the individual carrying angle. So further looking at the elbow joint, it's a very stable joint. There is a very small amount of accessory movement present, but because of the bony structure of the elbow joint, it is a very stable joint with minimal accessory motion. You can, with the elbow flexed, you can get some traction and do some posterior joint mobilization, and you can also get some medial and lateral joint play. So there are actual medial and lateral joint mobilizations for the elbow as well, which, depending upon how you're looking to get your motion back, you may want to consider utilizing. So in looking at our open and closed pack positions, you have to consider both of your joints when you're examining this. So with the humeral ulnar joint, your closed pack position is full extension. So at full extension, the humeral ulnar joint will be most closely approximated. With The open pack position, you want to position the humeral ulnar joint, you want to position the elbow in 70 degrees of flexion and 10 degrees of supination. The humeral radial joint, the closed packed position is 90 degrees of flexion with 5 degrees supination. Your open packed position for the humeral radial joint is full elbow extension with supination. So you actually will have the elbow fully extended with the open pack position of the humeral radial joint, unlike the humeral ulnar joint, which makes full extension the closed pack position. Looking at the joints and the arthrokinematics, so we look at our convex concave rules with the humeral ulnar and humeral radial joint. With both of these joints, the roll and glide will occur, the roll and slide will occur in the same direction. So in both instances, in the open chain, which again primarily most of the stuff functionally you'll be doing will be in the open chain, your the ulna, the concave surface of the ulna with the articulation with the humerus, so your roll and slide will occur in the same direction there. And it's the same thing with the humeral radial joint. The radial head glides over the capitulum. The radial head has a concave surface on it as well. So in both instances, your roll and glide will be occurring in the same direction. Looking at the radioulnar joint, the proximal and distal articulations. So you have two articulations when you look at the radioulnar joint. You have a proximal radioulnar joint, you have a distal radioulnar joint. The joint itself is classified as a pivot joint with 1 degree freedom of motion. So pronation and supination are the motions obviously that will be occurring at the radioulnar joint. The plane and axis will occur. It will be transverse plane, vertical axis. When you look at the axis of rotation, so essentially what's going to be happening is the radius pivots on the ulna. However, the axis of rotation goes through both parts depending upon whether you're looking at the proximal or distal. So if you look at the proximal radioulnar joint, the axis goes through the head of the radius. The distal radioulnar joint, the axis of rotation goes through the ulnar styloid. So the axis of rotation actually goes at an angle looking at those two articulations, and you can see that on the pictured on the slide. Your kinematics, your range of motion, pronation and supination. With supination, you have 90 degrees of motion. Pronation, there's typically a little less, about 80 degrees of pronation. Your joint end feels will be firm for supination and firm or hard for pronation. With pronation, it sort of just depends on how much pronation the individual has. If they have a little extra pronation, you might get more of a hard end feel, just because of the fact that you'll get some contact between the radius and ulna. So it could be either firm or hard when you look at the end feel for pronation. The arthrokinematics, just looking at the overall stability, at the proximal radioulnar joint, the annular ligament provides a lot of stability to this joint, keeping the proximal radius and ulna together. At the distal joint, you have an articulating disc, the triangular fibrocartilage complex, which is at the wrist, actually also articulates between the radius and the ulna. So while that acts as a structure at the wrist joint, it also goes in between the radius and ulna and provides some stability there. The convex concave rules are going to be different at the radioulnar joint depending upon whether you're looking at the distal or the proximal. So if you look at the proximal radioulnar joint on the illustration, you have the convex radial head moving on the concave surface of the ulna. Distally, you have the concave surface moving on the convex. So as you look at this, when you're looking to mobilize these joints, you have to take into consideration which one you're mobilizing as far as trying to determine how you want to get your range of motion back. Because at the proximal radioulnar joint, you will be moving your convex on your concave surface, whereas at the distal radioulnar joint, you're going to be moving your convex or your concave on your convex. Okay, so you have to look at whether you're going to be mobilizing the proximal or distal radioulnar joint and how you would go to mobilize that.